Hello and welcome back to our next portion, that is the tonsils anatomy. Here, don't we can waste any time. We can move forward to our next slide and start with our tonsils anatomy. Okay, basically, what is the tonsils? It is the mass of the lymphatic tissue located in the pharynx. It is a part of the mucosa associated lymphoid tissue that is in the short form MALT system. It forms the Welder's lymphatic ring, first line of immune defense, most important from the BCQ's point of view. It is located at the junction of oral cavity, nasal cavity, and pharynx. Act as the immunological senescence against inhaled and ingested pathogens. So you can remember that these tonsils contain the Welder's ring. So what is Welder's ring? It is a circular arrangement of the lymphoid tissue surrounded oropharyngeal isthmus. It is a complete immunological ring of the pharynx. It is named after a scientist. What is the embryological origin? It derives from the endoderm second pharyngeal pouch, that is palatine tonsil, lingual tonsil and pharyngeal tonsil. There are three types of tonsils. Lingual tonsils, endodermal origin, posterior one third of the tongue. Pharyngeal tonsils, ectodermal and endodermal junction. Develop during the third to fifth month of fetal life. Reach maximum size at puberty, that is 12 years. Naturally involute after puberty, physiological regression. It is replaced by the fibrous or fatty tissue in adult. What are the types of tonsils? Palatine, pharyngeal tonsil, also known as adenoid, and lingual tonsil. Palatine tonsil, it is a paired lie in the tonsillar fossa between the palatoglossal and palatopharyngeal arch. Here we can see the sagittal view of the pharynx. So you can locate where it is. Mostly clinically significant tonsillitis and tonsillectomy. Clinically, if the tonsil is enlarged, then we can do the tonsillectomy. Size approx 2.5 centimeter into 2 into 1.5, length, width, and height. Crypt 10 to 15 tonsillar crypts are located into the palatine tonsil. Pharyngeal tonsil adenoids. You can hear about the adenoids. It's basically enlarged when there is a seasonal variation. So it is a single located on the posterior wall of the nasopharynx. When it is enlarged, when adenoid, it's caused nasal obstruction, ear problem, and in future in approx sometimes it can involve the lungs. Reach maximum size 3 to 7 years, then involute, no crypt, plical lie mucosal fold instead covered by the pseudostratified ciliated columnar epithelium. Lingual tonsil, single mass of posterior one third of the tongue, that is base, covered by the same stratified squamous epithelium. Above pharyngeal pseudostratified, here stratified. Multiple small crypt via single crypt pharyngeal, rarely removed surgically, difficult access, enlarged when palatine tonsil removed. What is tubal tonsils? It is a, you can say it is an accessory tonsil located around eustachian tube opening in the nasopharynx, protect middle ear from the ascending infection. When it enlarged, it causes otitis media with effluent glue ear. Remember that mainly tonsil involve the ear. So if a patient present with the ear problem, you can check the tonsil region too, because sometimes we don't know why this ear infection occurs. Sometimes due to the tonsil it may occur. Palatine tonsil detailed. Location and boundaries. Lie in the tonsillar fossa between anterior and posterior pillars, anterior palatoglossal fold, anterior pillar, cranial nerve 9 and palatoglossus muscle, posteriorly palatopharyngeal fold, posterior pillar, palatopharyngeus muscle, superiorly overlapped by the soft palate, inferiorly tongue base. What is the surface and structure? Medial free surface faces oropharynx 10 to 15 crypt open here. Lateral deep surface fibrous capsule adherent to superior constrictor. Tonsillar sinus intratonsillar cleft remnant of second pharyngeal pouch. Pellicite triangularis semilunar fold partially covered anterior surface, non-encapsulated medially encapsulated lateral by fibrous tissue. What's its histology? Mainly two important points: lymphoid follicle with germinal center, that is B cell zone, interfollicular T cell zone, plasma cell secretory IgA. Remember, immunoglobulin A is involved in this histological portion, and immunoglobulin A is defense mechanism. Here you can see above the figure, you can locate every portion where tonsillar base, trabeculi, crypts, germinal center, etc. What are the blood supply, nerve, and lymphatic? Arterial supply. Main dominant artery is tonsillar branch of facial artery, ascending pharyngeal artery branch of the external carotid, ascending palatine artery branch of the facial artery, dorsal lingual branch of lingual artery, lesser palatine artery branch of maxillary artery. All branches enter at hilum, lateral surface, or from tonsillar bed. Note: no single artery plexus around capsule. Venous drainage: peritonsillar venous plexus, pharyngeal venous plexus, lingual vein, and internal jugular vein. Paratonsillar vein danger in tonsillectomy. When it damages, it causes major bleeding. Nerve supply: cranial nerve 9, main supply glossopharyngeal nerve, lesser palatine nerve, cranial nerve trigeminal branch of the maxillary nerve, sensory tonsillar branch of the cranial nerve 9, pain in tonsillitis referred otalgia, via cranial nerve 9, Jacobson nerve tympanic branch. It is most important from the vesicles point of view. Here you can see it's probably main. Apart from the main, there are some other, but you can remember at least main supply. Lymphatic drainage: primarily jugulodigastric node, tonsillar node, also upper deep cervical node, jugulodigastric senacial node of palatine tonsil, enlarged in tonsillitis, tender cervical lymphadenopathy. What are the functions? Functions: immunological defense, antibody production, antigen processing, immune tolerance. What is immunological defense? Act as a first line of immunological defense of the aerodigestive tract. Sample antigen from oral cavity and pharynx. Immune surveillance. Rich in beta lymphocyte and B lymphocyte and T lymphocyte in organized follicles. Germinal center produce antigen specific B cell and antibodies. Produce security IgA. Remember IgA. First antibody in mucosal immunity. IgG and IgM also synthesized within tonsillar tissue. Plasma cell, terminally differentiated B cell are abundant. Critical immune organ in children ages 4 to 10 years. Antigen processing, crypt, traps, and concentrate antigen from food and air. Dendritic cell and macrophage present antigen to T cell. T helper cell activate B cell, clonal expansion, and memory cell formed because B cell form the plasma and plasma form the memory cell. Long lasting immunity. Immune tolerance prevent exaggerated immune response to harmless antigen. Regulatory T cell twig produced in the tonsillar tissue, important in preventing autoimmune reactivity. Balance between tolerance and defense. Key fact: tonsils are not essential for immune function in adults. They can be safely removed. However, in children under 8 years, tonsillectomy may temporarily reduce serum IgA level. Always weight risk vs benefit. Clinical correlation: acute tonsillitis, most common caused by the group A beta hemolytic streptococcus, also viral Epstein-Barr virus, adenovirus, Staph aureus, and pneumococcus. Symptom: patient present with sore throat, fever, odynophagia, and halitosis. What is halitosis? When you can eat anything, there is a bad smell from the mouth. Signs: red swollen tonsil, white yellow exudate on the crypt when you can examine the patient. Treatment: simple: antibiotics, penicillin and amoxicillin for 10 days, antipyretics for fever. Peritonsillar abscess, quinsy. Quinsy, what is quinsy? Pus between tonsillar capsule and superior pharyngeal constrictor. Complication of acute tonsillitis. Symptoms: severe unilateral sore throat, trismus, hot potato eyes. Signs: uvula deplaced contralaterally, bulging soft palate. Treatment: incision and drainage, because pus is always we can even if even if any portion of the body develops, we can do incision and drainage and treat it with antibiotics. And interval tonsillectomy. Chronic tonsillitis and adenoid. Recurrent tonsillitis 5 to 7 episodes per year. Enlarged tonsil, obstructive sleep apnea, and snoring. What is obstructive sleep apnea? We can discuss in the next slide. Adenoid hypertrophy, nasal obstruction, mouth breath, glue ear, otitis media with effusion from eustachian tube blockage, adenotonsillectomy indicated in symptomatic hypertrophy. Here you can see which structure block and which cause symptom. Tonsillectomy uh, technique: cold dissection, gold standard, coblation, and electrocautery. Here we can mainly do the electrocautery. Complication: primary hemorrhage less than 24 years, secondary 5 to 10 days. Danger: paratonsillar veins which cause major bleeding, and then facial artery because it is majorly close to that area. What is a referred otalgia and relations? Referred otalgia we can read in the we can teach in the previous slide that it is mainly caused by the cranial nerve 9, that is glossopharyngeal nerve through the Jacobson nerve and to the tympanic plexus to the ear. Medially, superior pharyngeal constrictor and facial artery 1 to 2 centimeter. Posterior carotid sheath, internal carotid artery, internal jugular vein, vagus nerve, and cranial nerve 10, that is vagus nerve. Infectious mononucleosis caused by the Epstein virus, exudative tonsillitis, lymphadenopathy plus splenomegaly. Avoid amoxicillin. Remember, in infectious mononucleosis, we don't give the amoxicillin to the patient because it causes rash. Complication of tonsillar disease: local complication, peritonsillar abscess, retropharyngeal abscess, parapharyngeal, Ludwig angina, spread to the floor of the mouth, mainly involve the submandibular gland, epiglottitis, airway obstruction, hemorrhage. Regional complication: otitis media via eustachian tube, sinusitis, postnasal drip infection, cervical lymphadenitis, jugular-digastric lymph node involved. Lemierre syndrome. It is nothing. It is internal jugular vein thrombosis due to the Fusobacterium. CST, cavernous sinus thrombosis. It is a rare. Mastoiditis via eustachian tube spread. Systemic complication: acute rheumatic fever caused by the group A beta hemolytic group B beta hemolytic streptococci, involve the molecular mimicry, mainly heart. Post-streptococcal glomerulonephritis, it is immune complex in kidney. Septicemia, Lemierre syndrome, when internal jugular vein thrombosis occur. Reactive arthritis, erythema nodosum, scarlet fever. Same from the erythrogenic toxins from the group A beta hemolytic streptococci. Tonsillectomy hemorrhage, primary within 24 hours due to the ligature slip. Secondary 5 to 10 days post-operative due to infection, management IV antibiotics, return to theatre, vessel ligation, blood transfusion if needed. Life-threatening facial artery or tonsillar artery injury. What is obstructive sleep apnea? It is a when there is a massive tonsillar hypertrophy or upper airway obstruction occur during sleep. Apnea episode, patient wake up, patient even didn't sleep, hypoxemia, oxygen concentration decrease in the blood. Sleep fragmentation, in children it causes hyperactivity, poor school performance, bedwetting, and growth failure. Diagnosis: overnight polysomnography, sleep study, treatment: adenotonsillectomy, curative in 80% of the pediatric obstructive sleep apnea. So here we can end with this tonsillectomy, tonsil and its anatomy, clinical correlation, etc. You can see here every point is important from the basics point of view. So if you can go through that slide, you can learn every point and it may easy for your basics portion. Thank you so much. Have a nice day and wait for our next topic.